Okay, we're not on yet, are we?
I guess we are. Oh, are people in? Hi. Hi, everyone.
People are in the room?
They're coming in.
How come we can't see them?
It's down on the bottom for us participants.
Ah, okay.
So we won't see your beautiful faces, which makes me a little sad, but we get to look at each other, which
Yeah,
is awesome.
this is a plus. Welcome everybody to our Q&A tonight, hosted by myself and Karese.
We are so happy to be here. There's nothing we like more than answering a bunch of questions, because I know when I was starting, that's all I had was questions, like 1,000,010 questions.
Yeah, for sure. Absolutely. And we have a good set of questions that have already come in. So we'll go through those. And then any other questions you have, you can enter into the chat box. Oh, so Rosemary said, glad to be here. We're glad you're here.
Yeah. Thanks for being with us tonight. We appreciate you.
All right. Well, I guess we'll just kind of get things going with our first question. Let me just pull it up here. All right. Best placement of myofunctional therapy during expansion therapy when using expanders and aligners to follow.
That's an interesting question. Get that a lot, especially when you get people who've been doing their own research online and so forth. You're always going to be answering this question and trying to figure it out. I think the best answer is that it's a collaborative answer, honestly. Something you have to work out with your provider, whoever's doing the appliance. Different providers like different things. Some appliance and expansion providers want the tongue tie to be released first because they believe that that's going to help with the appliance. If the tongue is able to get up as opposed to being restricted, it's able to get up and help the appliance get the expansion that it needs. Others believe along the lines of, if we don't expand, you're putting yourself at more risk. If without the tongue space, the tongue is going to fall back, and even more so now that it's released. And so then you're putting yourself at more risk for, more incidents of apneas and sadness.
Absolutely. And I think you kind of answered a little bit of a different question there, but definitely a question we still get. I think you were answering, where does tongue tie come into expansion?
Oh, is that not?
That is not what the question was. The question was, where does myo come into the expansion process? But still an awesome question to answer, because that's another fan favorite to ask. But as far as where does myo come into expansion, that's going to also depend on your choice of expander. So I don't know if this particular expansion process you're talking about, if it's a fixed expander or a removable expander. If you're in a fixed expander, it's going to be pretty difficult to do myofunctional therapy with that in, because we're not really going to be able to get that tongue up in the roof of the mouth. There are some myofunctional therapists that will do some myo while in a fixed expander, working on the lips, working on some nasal breathing. For me, I don't necessarily love to do that, because I just feel like if we know to breathe really well, we have to have that tongue resting up in the roof of the mouth, and we know we're not going to be able to have that with that expander in. I just kind of think it's a little bit counterproductive. Of course, it's a case-by-case thing. So for me, I want to be able to optimize our time that we are in therapy. So I would want the patient to go through some expansion and then do their myo. In some cases, we start myo, pause myo while in expansion, and finish myo. And Karese, I don't know if you want to answer, if you have anything different to say to that.
No, I'm just apologizing now for answering the wrong question earlier.
I still think that was really great that you answered that way, because I'm sure it would have come up at some point. But if you're in a removable expander and you're able to have that tongue to palate contact when doing the exercises, then I think that you are good to go. If you're using MyoBrace, Healthy Star, a myofunctional guidance appliance, something like that, we definitely can do myo while we're using those. It's really just those fixed appliances where myo can get a little bit tricky in accomplishing all of the goals that we want to accomplish.
Yeah.
All right. Are there any updates on a governing board for OMT?
No, 0 updates.
Karese is the one to answer this. Karese is our president of the IAAH, which is the International Association of Airway Hygienists. If you are not already a member, you should be. It is a great association to be a part of, very supportive of our RDHs that are involved in Airway. A very reasonable price, $25 to $50, depending what membership you're going to do. CEs you get with that membership. It's a win-win. And we could post that information in the out of the app group for anybody that is interested in it. Or Karese, it looks like she's going to type it in right now for us. She is on it. Okay, next question. Let's see. What is the big picture goal for patients with sleep apnea?
Big picture goal?
Yeah, I'm not sure from what direction. This is being asked by a dentist.
Myo, I would assume. What's
Perhaps.
Myo's role in sleep apnea?
Yeah, let's take it that way, seeing as we're here to talk about Myo.
Okay, so where the research has shown, or where we are with myofunctional therapy, is that we can help to potentially decrease the AHI. A lot of that is going to come from really just an increase in their ability to get the tongue and keep the tongue up and out of the airway. In some instances where we're doing a lot of the work with the soft palate and so forth, you're getting and just freeing up more space. I like to use a little analogy, and I don't know, tell me if you love it or hate this analogy. So when you have somebody who has six-pack abs and they go down and they lie down in bed, right? Those six-pack abs don't move. Like, they still look phenomenal. They lie there, they're still there. The gravity doesn't push them down, like nothing gets smushed. When you have somebody who has more of like a beer belly or is just overweight, gravity happens, things shift, nothing kind of looks the same, right? So I like to liken that when I'm doing my little analogies for patients to obstructive sleep apnea. The very first few stages of sleep is going to be all of the muscles kind of relaxing, right? And so with now gravity and muscle relaxation, you're really at a increased rate or possibility of having a little collapse or having multiple collapses of that upper airway. And so if it's just a little bit more like we're working on the soft palate, we're working on a lot of these, we're working on the tongue, posterior tongue, we're working on a lot of these things. Once we start working on that stuff and you get increased strength and awareness, then it's just a little more open, just like if you had six-pack abs, but in your throat. Terrible analogy, good analogy?
I love that analogy.
Okay.
I'm also just answering somebody's question here. No, that was absolutely fantastic. And again, as myofunctional therapists, it's not our, we never want to promise anything to patients. So, we're not going to cure them. We're not going to get them off their CPAP. We're not going to get them off of their oral appliance. We are there for what our job is as myofunctional therapists, right? Which is to optimize that oral rest posture, and to Karese's point, working on those oral pharyngeal exercises that can help with those muscles that do take part in obstructing the airway. Somebody just asked what the organization was. I think I answered you. Karese typed it in the webinar chat. So it's www.myiaah.org, stands for International Association of Airway Hygienists. All right, let's see. Elaine said, great analogy. Love it. A kiddo of mine had adenoids and tonsils shaved, but she is inflamed all the time during winter. Gets sick easily. Can we still do myo when the child is sick, or put it on hold for a few weeks?
This is a tricky one. I think it's going to depend on a lot of different factors. Some of that might be what kind of things you do adjunctively with your myo. There are some people who do some pretty cool, funky, breath work, or work really intently with nasal hygiene routines, or do more holistic methods. And so they might be able to get some decongestant to happen a little bit quicker than just traditional myo. If you're just doing just myo and they can't breathe, you might want to just take a little clinical vacation.
Just a little bit, just because you're not going to really be able to accomplish your goals in that week that they're slumped open, mouth open, having no choice but to breathe through their mouth. So again, we're all about optimizing the time that we have to spend with these patients, especially because as RDHs, it's not a covered expense. So these patients are paying, out of pocket. So I always like to be able to optimize the time that we have together. Any opinion on xylitol within nasal sprays?
I love it.
Love
I'm
it.
obsessed with
Clear,
it.
yeah, clear nasal spray, 100%. And if you want to answer more to that, Catherine, was there something on the flip side where you heard xylitol in nasal sprays wasn't good, or if it was just something that you were concerned with? All right, next question. What would a program for a kid age 4 to 6 look like for y'all? And oh, I even said it in the person's accent. I don't say y'all. That was fun. If they're in need of a lingual frenectomy as well.
Ooh, I love that question. You know why I love it? Because we're going to kind of like preview a little something we have coming up
Yes.
a little later on, like in a couple of months.
Yeah.
But what does a program look like for ages 4 to 6? Now that's really going to vary on their maturity and their developmental like readiness for a full myofunctional therapy program.
And parent level of commitment.
Well, if the parent's not committed, they shouldn't even be doing a frenectomy at all. Like,
Touche.
Yeah, do not pass go, do not collect $200. But if they're going to do a full myofunctional therapy program and you're just putting in the frenectomy stuff, it would just look like regular myo. But if they are not developmentally ready to do a full program, then it's going to look like really a couple of pre and post visits to help prep the family, get them ready for active wound management and really like what kind of movements they're going to need to do, the child is going to need to do, or the parents may need to assist with in order to achieve a little bit better.
Yeah. And sometimes I feel like with those tough age groups, you always really want to prep the parent. Some parents are like, it's like they can't look past the fact that the child isn't really behaviorally ready because they want the release done so bad. But at that point, then you're risking needing a revision. So, we want to make sure that these children are able to sit in the chair. A lot of parents don't want to have to put their kids under anesthesia just to have a release done, which I totally get and agree with. So unless, of course, they're seeing an ENT, already having tonsils, adenoids out, something like that. So you just want to make sure that they are ready because it takes a lot, and it takes a lot from the parent to be able. Karese can talk to this. She had her daughter had her tongue tie released. They need to make sure that they're able to get in there and that the child is actually going to let them get in there. So even if we're not able to do a full program with this patient or even a mini program and we're just doing like pre-post-op, it's really important that those families are practicing those stretches beforehand as well. And not just once, they have a wound in there and they're already, uncomfortable and in pain. The question about the nasal sprays. So it was just a general opinion. The ENT didn't like it. Yeah, well, not
Did the
surprised
ENT
there.
give you a reason, or does the ENT just not like it because he thinks like,
we should only be on like, yeah. There are other options. You can look into AYR has like a saline nasal gel. There's Pulnaris. I can't think of any other nasal sprays off the top of my head that I would recommend. I really only recommend clear nasal spray to my patients.
Elaine had asked, how would you reply to the comment of, quote, if I am clenching and grinding at night, isn't my mouth closed to do this? So why would you think I mouth breathe at night? End quote.
Yes, I have actually gotten this question before. So you want to think about, why are you clenching and grinding, right? There has to be something going on with that airway, some kind of resistance, negative resistance that's happening, that your body, is trying to open that airway by doing that clenching and grinding. And there's a great article by, oh my God, why am I blanking on his name? Dr. Gerald Simmons. He's a sleep physician, where he talks about your body being a protective mechanism when it comes to clenching and grinding. So we always want to rule out there being an airway issue when we have patients that clench and grind their teeth. Is there a stress component to it? Yes, but we want to make sure that there is not an airway thing that's going on. So again, how are we going to answer this? So if I'm clenching and grinding, why would you think I mouth breathe at night? I would literally just say that we want to get down to that root cause of your clenching and grinding. Why did you have to clench and grind to begin with, right? Because you're not breathing well. You're not breathing well through your nose.
Right. And sometimes it doesn't have to be blatant mouth breathing. I mean, somebody could just have their lips apart ever so slightly, or their tongue sitting down on the floor of the mouth. It doesn't have to be like very overt mouth breathing.
Like Napoleon Dynamite, right? Like people take major offense when you talk about their lips being apart. They think like you mean they're catching flies. And that is, to Karese's point, not necessarily some patients, but even having your lips apart 3-4 millimeters, that is still an incompetent lip seal. It's not a lot, but those lips are still parted. And when we have those lips parted, more often than not, that tongue is going to be in the bottom of the mouth. It's very awkward to have your tongue up and your lips open. Like, I don't think I've ever come across somebody that actually does that.
Good answer.
Do you find people stop grinding while on CPAP? I have patients that have significant occlusal wear. We discuss sleep and association with sleep disordered breathing, and then they say they wear a CPAP and don't grind. Thoughts? Yeah, I mean, if the CPAP is going to be what's managing their airway at night, I can understand that. But the concern then is, what about during the day? Like, they're not breathing well at night. They're also probably not breathing well during the day. And yes, they're not laying supine and they don't have all the, forces of gravity working against them where things are collapsing more. But a lot of these patients are still in a chronic sympathetic state all day long. And that's why CPAP is great. It's going to help manage that, sleep apnea at night, but we really want to pay attention to also what are these habits during the day.
And I think what we need to remember is that CPAP is, the continuous positive airway pressure machine. It is manually keeping open that airway. So there's no need to grind. Why would you need to grind? And so if they're saying, oh, but when I wear my CPAP, I don't grind. Great. When you wear your CPAP, your airway is being held manually open. So that's why you're not grinding.
Okay. How many weeks pre-post-op for frenuloplasty? How long is a full myo program?
Loaded question, Cynthia.
Yeah.
Super loaded. It's going to vary. It will literally vary for everyone. You might have somebody who's very, very, very anteriorly tied, like absolute true ankylosing. And at that moment in time, that's not somebody that you can take for a couple of weeks through some pre-myo, prep, because they can't really do much. Whereas somebody who's maybe more posteriorly tied is more likely to be able to do some work where we can actually work on some of the muscles and really engaging as much as possible.
Somebody had just said how an ENT at a hospital near them recommended clear nasal spray and an neti pot for their 17-year-old daughter.
Awesome.
Pretty amazing, right? I responded with, where do you live? Okay, I have a 7-year-old patient who recently had his adenoids removed, but still has a tenacious mouth breathing habit. He just had his tongue tie released, so planning on working on nasal breathing in the near future. What are your go-to techniques or exercises to switching a patient to nasal breathing?
Loaded question.
So there's a lot of things to consider here. First of all, you can remove the obstruction, but that's 7 years of bad habits, right? That's 7 years of that tongue resting in the bottom of the mouth, 7 years of only knowing how to breathe through the mouth. They're not automatically gonna close those lips, put that tongue up there and start breathing through their nose just because that obstruction's gone. So that's where that myo and that breathing re-education comes in. You also want to take into consideration what happened to that structure from those enlarged adenoids or that nasal congestion, nasal, impatency. Do they have a high narrow palate? Does expansion have to take place? We have to think about, that upper jaw is also the floor of the nasal cavity. So do we have to go through some expansion to also get some really good nasal breathing going on for this patient? Do you have anything to add, Karese?
Go-to techniques or exercises. It's going to depend on what you're working on. Some people most myofunctional therapists are into, I was going to say some, it's like a lot of you guys are into the buteyko breathing. But there's a lot of other breathing methods and there's some things that I really like, but you would definitely, include some mouth, obviously not some mouth work, some breath work. You would definitely include some breath work of some shape or form, definitely, to help them facilitate more of a belly breathing and a natural breathing pattern.
Yeah, definitely I will say one thing for that age is you really need to get them to understand what you mean by belly breathing by using their diaphragm, whether it's getting the hands on the belly, having them lay down, placing something on the belly and having them breathe in and out and watching, what happens to that stomach and that diaphragm area as they're nasal breathing.
Pelvic floor work, super important too, because that's going to help you engage that diaphragm. Sometimes they need a little bit of that too. So if you work with an occupational therapist or a physical therapist who does some of that, I think that's incredibly helpful in the retraining process.
Absolutely. All right, let's see. I hope I'm going in order here. Do you recommend an occlusal guard with a CPAP then? The idea is that the airway is open, but what if attrition is pretty moderate? So if they stopped clenching and grinding, then no, I don't think that there's any need for it anymore at that point, right? The damage was kind of already done to their teeth. There are patients that do use oral appliances along with their CPAP. So that, is a possibility, but if they're not clenching and grinding anymore, I don't remember if this is the same person that asked about the clenching and grinding last time, but there shouldn't be any reason they would still need to use it if they're going to actually use their CPAP every night like they should, right? That's the thing. CPAP is the gold standard, but compliance is not really the greatest with CPAP. So that's something that we would really want to make sure that they're actually being compliant with it.
Agreed.
Okay.
And telling you where she's from, because you said, where is she from?
Oh, yes. Okay, cool. Central PA. Love it. In an adult with a tongue tie. Whoa, the questions are going up. Okay. In an adult with my eyes just went crazy. In an adult with tongue tie and who needs myo with a narrow palate. So an adult tongue tie needs myo, narrow palate. Is it possible to do tongue tie and myo and see some natural expansion once the tongue is able to be in the proper place?
I feel like you were in my last consult, Nicole, because that's literally the question that the person was asking me. I have a tongue tie, I have a narrow palate. It's am I able to do the myo? Can I get expansion with the myo? If you do get some expansion with myo, it's going to be mild at best. All of you RDHs or dental professionals who are in here, because I know there's a couple of you that aren't dental professionals. Hi, allied health professional friends. The 2 to 3 millimeters that you can count as healthy periodontal space. Yeah, that's how much you're looking at for transverse width, possibly with myo. Yeah. So 2 to 3 millimeters, how minute is that in the grand scheme of things? So it's probably better that they do get actual appliance expansion.
All right. Okay, Dr. Bob, during sleep, the clenching grinding is brief, intermittent, whilst the mouth opening is more continuous until air intake becomes critically low, the bruxing takes place. Thus, the two do not happen at the same time. So
the mouth breathing separates from the clenching grinding.
Yes. So that's something as well that you can tell your patient then. You're not really going to do, you physically can't really do both at the same time.
Questions are going to move, Brittany.
Yeah, I know. I don't like it. What computer program have you found to be the best for a teledoc myo business? I use Simple Practice. I do love it. They did increase their prices, which I don't love, but I'm used to it. I love it. So I'm still with them.
Crazy. I love Doxy because it's free and I'm a frugal Fran. So if Doxy ever started to
oh, we're talking about a telehealth platform.
Yeah.
All right. My bad. I use Doxy
don't you
too.
Oh, okay.
I don't use the telehealth through Simple Practice because it annoys me with the screen. And I'm just used to already using Doxy. So
yeah, doxy.me. You can sign up for a free account. It's wonderful.
I apologize, Elaine. I thought you were asking about a software, electronic medical health records platform.
If you did mean that, then just let us know, because then I'll tell you what I use.
Yeah, well, let's just say it anyways, because it's probably a question.
Well, I use Charm EHR. I like charm. Charm also free to a point. I mean, I see too many people for it to be free for me anymore. But once you get over 50 appointments a month, then it's 50 cents each one. So like bare bones would be $25 a month, which is by far better than most of the other programs that I've seen out there.
1,000%.
Yeah.
And Charm is really great. I used to use Charm as well. It's very user friendly. I like the way Charm looks. We actually use Charm for MyAware. So I still actually use Charm on a daily basis. Yeah, we use Charm for MyAware. All right, Karese, will you elaborate on pelvic floor? Cynthia asks.
Sure. Your pelvic floor is okay. Is this TMI? I was gonna say like ladies who do Kegels or Kegels.
No, come on. We're all friends here.
That's working your pelvic floor. There you go. That's your pelvic floor. Listen, the pelvic floor serves as like the stability or the foundation for that lovely little diaphragm, right? So your diaphragm is now what's really going to help with the lungs and the breathing. And so if you don't have the support for the support, it's going to create issues. No, I could go deeper. Let me not. Let me not, because I feel like it would be getting into TMI. I'm like, here are some clear signs that there's some pelvic floor disruption, but don't. No, it's fine.
Okay, to be continued, guys.
Yeah. Message
okay, Lindsay asks, what are your best tricks for oral habit elimination in younger kids, 4, 5, 6? Do you use unplugging the thumb program? What other tricks are you using?
First off, hey, Lindsay. That's it.
Hi. Okay. Okay. I didn't know if there was more there.
Do you use unplugging the thumb, Brittny?
I use parts of unplugging the thumb. So for anybody wondering what unplugging the thumb is Sandra Holtzman's method. What would you call it? Program for habit elimination. I think, there's other parts to the habit that you want to truly understand. So it's not just about like, slapping something on the finger that isn't going to allow them, to suck their thumb at night. Because also, what about during the day? What about when they're at school? How often are they doing it? Are they doing it at school? Is it around certain people? Is it around certain items? Is there a trigger? Is it a blanket? When they have the blanket in their hand, they put the finger in their mouth. So there's other things you want to understand about the habit. And Karese, if you want to talk about, what's the book called that you like? Atomic Habits? Power of Habit?
Oh yeah, The Power of Habit.
Power of Habit.
Yeah, really great book to read to really understand habits, like why we have them and so forth. So I use more of a cognitive behavioral therapy technique where I'm really having the parent hyper analyze. So if we're doing a myofunctional therapy program, what we wind up doing is we engage these people in so much conscious awareness about where their tongue is positioned, where is proper oral rest posture for them, and their breathing and everything. And so I get the people to be hyper aware to the patient, not the patients, the parents, to be hyper aware as well of what's going on around this habit. So when are they thumb sucking? What's happening? What does the environment look like around that? Like, you have a good week where you're journaling this stuff for me. And then from there, we are going to deep dive into what might be a cause, what might be a trigger. At that point, a lot of them pretty much figured it out. Like, anytime little Susie is hungry, she winds up, with the thumb in her mouth. And then, once we serve lunch or dinner, it kind of dissipates. And then she goes to bed maybe without some snack or something, and it winds up in the mouth again. I don't know. And so from there, we're kind of, troubleshooting.
Absolutely. And also make sure as well, the patient should be getting, referred to an ENT anyways, just to make sure there's airway clearance. But sometimes we see those habits as a response to there being nasal impatency. So we just want to make sure that they're not doing that habit just to really like open their airway, get their tongue out of their airway, jut that jaw forward. So you want to understand why they're doing that habit. Nicole asked, how often do you offer your myo course? More than once a year. I'm interested, but can't do the one coming up. Sad face. Oh, we're equally sad too, Nicole. That's okay. We absolutely do it more than once a year. For anybody else wondering, we do have a myo course starting T-Myo February 1st, which is next week on Wednesday. It is not too late to enroll. And then our course following that, I was just trying to check in my calendar. We're going to talk about it at the end. Karese, do you know the date off the top of your head? Is it like May 3rd? Wednesday, May 3rd will be our next course after that for the 8-week course. We also offer a 2-day course, which will be,
I believe in September is the next one, right?
no, April
Oh, sorry.
14th and
Oh, that's true. The 14th and
21st.
the 21st.
April 14th and the 21st. At the end, we'll have a slide up there so you can take a picture of it, and I'll have the other dates up there. But hopefully you can join one of those because we would love to have you, Nicole. All right, Kim says, just curious, your verbiage when you have a client or patient in a dental chair that is obviously tongue-tied, narrow, scalloped tongue, abractions, etc. You talked about some findings and discussed sleep, grinding, and so on, and they say they don't have any issues. Of course. I tend to not push the subject, just plant the little seed. Do you have anything simple and non-confrontational or pushy to say? I think that you have to meet patients where they are, and if they're not ready to hear it, I would document what you discussed, bring it up again at their next, recall, maybe leave them with different things to pay attention to, books to read, podcasts to listen to, just different things for them to pay attention to from now to the next time, that you're seeing them. But plant the seed. That's the best you can do. And hopefully the next time they come back, you'll be able to really start that conversation more. Karese, do you have any other advice?
It's really difficult because I'll tell you just from my own experience that it was something that I knew about in 2014 and I was aware of. I had a whole baby in 2015 and I did all the wrong things and I just really didn't get it. It took me a while to actually get it. Several CEs, several going through courses and so forth, like to really and truly get it. And it wasn't until another person told me that my child can't breathe that I was like, oh. It just really like that was the verbiage that did it for me. I don't know. So it's really difficult because you can have all the things, it can be very obvious, but if it's not the wording that's going to trigger them, they might just do nothing about it. And you just have to be okay with that. We can't save everyone. We really can't save everyone. We can only save those who want to be saved.
Good point. Okay, Candace says, what are your thoughts on the different appliances, Myo Munchie, Healthy Start, Habit Corrector, Myo Brace, Vivos for Kids, etc.? Do you use them as an adjunct to therapy? Pros, cons, thanks. Yes. The Myo Munchie is really the only one that we can get our hands on as myofunctional therapists, unless the Myo Brace like lip trainer or what's their
Myo
new?
Chew.
Yeah, their Munchie, the Myo Chew.
Myo Munchie.
Yes, their Myo Chew. You can order that as a myofunctional therapist. Now, of course, if you're working with a provider who does do Healthy Start, Myo Brace, Vivos, etc. Yes, we do work with patients that have these appliances. They are definitely a good adjunct to therapy. Pros, cons. I mean, the only con I would say is depending on the patient and their age, it might not be enough for them, right? They might need to go into rapid palate expander, go through one of Dr. Moralia's techniques, Dr. Boyd's technique to really get them where we want to be. You're only going to get so much expansion with like a Healthy Start Myo Brace type of appliance. So it just might not always be enough for that patient, but sometimes in the beginning, it's really all they can handle at that time.
I will say that all of those that you mentioned are removable appliances. Removable appliance require compliance.
Yes. Oh, I like that.
To be compliant, and that's very difficult for a lot of people when you put the control in their hands. This thing, just wear this thing for 18 hours and, have your 8-year-old do it for 18 hours a day. You find that it just doesn't happen, like people's busy lives and so forth. So
it's hard.
Yeah, that would be the biggest con, is that it requires the patients to actually have to do this thing.
Okay, I'm going to these other questions. Give me a sec, guys. I lost where I was at. Somebody asks, can my assistant become an oral facial myologist if she trains under me?
No. I wanted to give like
oh my God, I love you.
I'm sorry. I am so sorry.
Did you have something else you wanted to say? We're just gonna leave it at no.
Oh, okay. Okay. No, here's why. Okay. Now, most of the training companies will not train a dental assistant. Here is why, because the education is not standardized across the board. You can get into dental assisting many different ways. You don't necessarily have to go to a collegiate program or do any sort of post high school training. You could just get in on the ground floor and apprentice. And so with the myofunctional therapy, it's not just doing exercises. Okay. This is not like jumping on YouTube and calling yourself a fitness trainer and just doing exercises. Like that's not the way it works. It is actually a neuromuscular re-education program. And you have to understand a lot of the science behind it. You have to understand oral function. You have to understand oral development. You have to understand oral anatomy, all these things that you do get in a standardized education as a dental hygienist, as a speech language pathologist, as a dentist, that we can say and we can look to and say, oh, okay, you definitely got this in your education. You now have met a prerequisite to becoming a myofunctional therapist, not just, oh, you look nice, you should be a myofunctional therapist.
Very good answer. Okay. Sarah is curious about becoming a myofunctional therapist. We love that, Sarah.
Yay.
Stay tuned because we'll be talking about our courses. We think you should become a myofunctional therapist. You are an RDH, so you are able to become a myofunctional therapist. Okay. General question here from a doc. Aside from a tethered tongue, are there any other tissue ties we need to look out for?
Yeah, labial ties, both maxillary and mandibular, and then buccal ties. 1, 2, 3, 4.
Yeah, we definitely want to keep an eye out for all of those. I mean, sometimes, we come across patients that need all of them done. Okay, let's see. Help with patients who have trouble implementing swallow.
Okay, so here's the thing. It depends on where you're trained, because some programs will train you to do a little bit of everything in every single session with the patients. And so you'll start out day 1, maybe with swallowing, or session 2, second time you guys have ever met, they're working on swallowing. Whereas Brittny and I both independently, prior to ever teaching and then now continuing through us teaching, we both feel that you have to gradually build on these skills. Like swallowing is a combination of a bunch of different skills. And so you need to have some jaw stability. You need to have the ability to, disassociate your lips. You need to have some good suctioning skills. You need to be able to have great lingual function. There's a whole lot that goes into like working your way up to swallowing exercises. And so what I would suggest to you is to maybe rethink what came before you started working on the swallowing, if they're struggling, because there's something that's missing in your program in the beginning stages that really should have led up to that swallowing as a prerequisite.
Love that answer. Okay, next question. And Karese just did a wonderful lecture on billing for myofunctional therapy. If you are part of the IAH, you can listen to it for free. So how do you bill myo in the dental office? Does insurance cover this?
How do you bill for myo in the dental office? That is a loaded question. I mean, you guys like all these loaded questions. I did a whole hour presentation about how you fill out the billing form and like how you would do like a reimbursement form if you had to, like, there's a lot that goes into that. Does insurance cover it in most instances? No. Honestly, most people, you're going to have a hard time getting coverage. You are more likely to get the patient reimbursed if you offer them a super bill. If you don't know what a super bill is, then like message me separately and or join the next Team Myo course, because we talk about that as like a standard in our like basic courses. We're talking about insurance and billing and that type of stuff.
Absolutely. You'll know exactly how to fill out that form. Not that you're going to want to, so it's kind of a pain in the butt. But of course, we're going to do whatever we can to help our patients. Okay. How can I help my hygienists with motivating the kiddos? Great question. This is coming from a general sleep doc. Oh, Dr. Veronica, we met you at Airway Palooza. This is a very great question. And this is, again, stay tuned a little bit later because we're going to be talking about a course that we have coming up that we are focusing more on the younger kiddos, how to assess them, how to evaluate them, how to keep them motivated, all that stuff. I mean, generally, I would just say you got to find what interests the patient, what motivates the patient, and kind of stick with those things. How important is myo in treating moderate to severe sleep apnea? I think you kind of already answered this when we had that sleep apnea question before. However, well, I don't think you said this maybe before. Did you say how like with severe sleep apnea, like there's not much that myo is going to really be able to do for that?
I did not, but that you worded that perfectly.
So there we go. But mild to moderate sleep apnea, there is very great evidence that supports myofunctional therapy. All right, give me a sec, guys. Got to scroll down. My finger does not want to work.
While you're looking for that, let me answer this question. Okay, so Elaine had posted in the Q&A chat here that, and I think this goes back to the dental assistants and so forth, that she assumes that part of myo, I guess, would fall under scope of practice within a Dental Practice Act, laws, etc. You'd be very surprised to know, Elaine, that it is written in absolutely zero state practice acts. Like there is no mention of oral myofunctional therapy in any dental state practice act. In a couple of states, the ADHA did incorporate it into their PRs, but we have to remember that that is not a regulatory organization. That is a professional association. And so they don't determine the laws or the regulations. So it is written into absolutely zero laws. It is not regulated at all in any state in the country of America. So it actually doesn't fall into any scope of practice thing. It's just something, like I said, just having a certain prerequisites. I think it helps to legitimize the field as a whole, as opposed to accepting anyone as a myofunctional therapist.
Yes. Okay, open bite correction with clear aligners. Patient has a tongue thrust. Do you recommend myo before treatment, during, or after? Definitely not after.
One more time, open bite.
Yeah. I saw you looking at me a little funny. I thought you needed me to repeat that. Patient has an open bite, being treated with clear aligners. They also have a tongue thrust. Do you recommend myo before, during, or after treatment?
Not after.
That's what I said.
Your answer, right? I'm taking a multiple choice quiz. It's like not
right. After. I mean, I personally like to do the myo while they're in. Like, I want to be working with them while they're going through the Invisalign. I don't need them to finish with me first and then start Invisalign. I'm fine starting first and then they're going to get into it while we're in treatment. Again, most importantly, you just don't want to do it after, because if we're not correcting that underlying dysfunction, that bite will most likely reopen. So all that hard work that you did with those clear aligners, not going to be so great.
Yeah. Patricia asked, if you are a licensed hygienist in New York, can you do myo in Florida?
How funny is that with Joanne? Because she was in New York and Florida. Wait, so if you're
a licensed hygienist in the state of New York.
Oh, but you're living in Florida.
Can you do myo in Florida? Oh, you were talking about me now?
I don't know. I'm confused. So am I. So this patient, oh my God, guys, it's been a long day. This hygienist, you have your license in New York, but I'm assuming you're living in Florida now. So can you do hygiene or
myo in Florida? Listen, there's nothing saying that you can't, because it's not in your Dental State Practice Act. You're not acting as a clinical dental hygienist. It is a very gray line. I will say that for those of us doing teletherapy, the speech pathologists don't have this benefit because they have to work within the lines of the states that they are licensed in, but we do teletherapy with people all over the place. So technically, when you're doing teletherapy with somebody in, let's say you were in New York as a hygienist and you're doing teletherapy with somebody in Florida, technically you're already practicing in the state of Florida, just from New York, if that makes sense. There's nothing saying you can't. How's that?
So short answer, yes, you can.
Yeah.
And good for you for moving to Florida.
Yeah.
Okay, what is the best way to build your network? Get out there, be
Make
friendly.
friends.
Yes. Yes. Make friends. I mean, think about it. This is coming from another fellow RDH. How excited were you when people came to the office with treats, right? If they had treats in their hand, sure, I'll talk to you. If you don't got no treats, probably not really interested. So think about when you're networking, say with another dental office, who's really going to be the bulk of people that are seeing these patients? Really the hygienist, right? So you got to get them on your good side. You got to get that office manager on your good side so that you can get to the dentist. And you got to do that with yummy treats.
Yeah. I think that it's really important to make a lot of friends because we are doing something that is a little bit out there. Okay. So just when I say that, I don't mean that there's anything wrong with myofunctional therapy. I just mean that most people haven't heard of it or there's still some resistance even within the field for it. And so sometimes it's easier to talk about something new to your friend than it is to talk to a stranger. They can easily dismiss you. Like they don't know you. They have no investment in you whatsoever. And so they don't need to listen to you if they don't want to. But if you make a new friend, you just go there, you're bringing treats and you're saying, I would like to learn more about your office. And if there's anything I can do to help your practice grow, because that's what you want to do.
Two-way street.
You want to refer patients there at some point, right? How can I help your practice grow? If you would like, we can get together for coffee. I can come back for a lunch and learn, and we can kind of talk so that I can get to learn more. Suddenly now you're telling them about your kids. They're talking about, the soccer tournament, little Billy just won, and you guys are becoming friends. You're exchanging phone numbers, and then you can bring up Mayo a little later. I mean, it really is the most fun part about this is making a lot of great new friends.
Absolutely. And be confident, as well. Sometimes I think as hygienists starting out as myofunctional therapists and going to network with whoever you're going to network, oral surgeons, ENTs, orthodontists, whatever, sleep doctors, it can seem a little intimidating in the beginning, but remember that like you are the specialist, right? They want the services that you offer. You're going to be able to help their patients. You are the specialist in this field. You know more than they do about myofunctional therapy. So be confident, be yourself, and you'll rock it.
Yeah, I love it.
Okay, what is the best way to find a qualified myofunctional therapist in my local area?
Use a directory. Or just Google. Listen, guys, if you guys aren't on Google yet, you need to get on Google because the first thing, once you find out about anything new, is you Google it. Like,
sure do.
Yeah, everything is Googled. And so if you're not on Google My Business, you can't get found in your local area. So if there are people who would love to refer to a myofunctional therapist, but they can't find you and you're literally right down the street, not on Google. You need to be on Google. So get on Google. I would say look for a directory or just Google it, myofunctional therapist near me, and somebody needs to pop up. Make sure it's you.
Yes. And if this particular doc is listening and you want to even reach out to Karese and I to help you out, get you hooked up with somebody in your area, you can also do that. But yeah, Google is the easiest. Now, of course, you want to know more about them, their background, how long have they been doing it, who they have experience with, patient-wise, age-wise, things like that. That you'll know more once you have a conversation with them. But as far as just like strictly trying to find a myofunctional therapist, Google and directories is the way to go. I said age because that's our next question. What is the earliest age to start treatment?
Myofunctional therapy treatment, it's going to depend on their developmental readiness, but I would say age 5 approximately. Once they're school age ready, they're typically ready to start a myofunctional therapy program. What's your response, Brittny?
I agree. As far as a full myofunctional therapy program goes, yes, we definitely want them to cognitively be able to understand what we're asking of them. And again, we're going to be talking about different courses we're going to be offering where we're working with more of that, that age group that you're referencing. And I think this is probably a good time. Oh no, we have more questions.
Oh,
I didn't see
yeah.
those.
Well, can I put
Okay.
one up from the chat here? Susan says she's taken a class, but she's having a hard time getting patients to keep their appointments. She thinks the patients are talking to others and being told that it's something else, just like quackery. I am having a hard time getting started. She's a dental hygienist. Susan, I empathize with you. I know that it's very difficult if you are having the patients come in and they're doing a full evaluation with you. And at that point, they're not understanding, or at that point is where they're kind of turned off. I would encourage you to maybe go a little deeper with your evaluations, maybe write your reports. I started putting citations in my reports. That way there was research behind them. And so some of my patients actually, like, things have been booming lately, but some of my patients have been giving that report to their doctor who told them it was nonsense. And then the doctors contacted me like, oh, wow, what a great report. And I love that you had citations on there. So I don't know, just start putting more research behind your stuff. If you're not even getting to the point of the evaluation, like if they're just dismissing you from the get-go, I would revisit how you're having the conversations with the patients, because something there is not fully convincing them from the get-go that they're now going for a second opinion.
Yes. Sorry, I'm just reading a comment from Dr. Bob. I like the use of myo appliances, Munchie as an intro appliance to get them familiar with having an appliance in their mouth and to prime them for impression taking if needed. I like that. Okay, last question. How do you handle not getting discouraged when you hear of programs training non-RDHs, SLPs, et cetera, such as massage therapists and personal trainers in their myo programs? What actions would you recommend we can take to encourage more oversight in the field?
I am a huge proponent of the idea and the concept of abundance. So I don't feel threatened by the fact that there are other people out there that practice, especially if they're not fully trained or not appropriately educated prior to becoming a myofunctional therapist. I don't feel threatened as far as business wise. However, I think that it is something that we should address just to maintain a higher standard of care for our patients and a higher quality. And so I really think that coming together is the best way to, bring everything together, coming together as a whole. So whether
Great
that's
answer.
through the IAH or any other organization, but we really need to start banding together. It's too much dissension in the field.
Absolutely. Okay, I'm going to share my screen.
Yay.
Let me know if you can see this. I don't really ever use Google Slides, so I'm going to click slideshow and hopefully you guys will see it.
I see it.
Yeah?
I love it.
All right, good stuff. Okay, guys, so our Team Myo course that Karese and I teach, if you're new to Myo, an existing myofunctional therapist, just want to learn a little bit more, want a little bit more knowledge, we have two different options. So we have a 2-day live on-demand hybrid course for dental practice integration. We also have an 8-week course. If you're going to go more the private myofunctional therapy route, that's definitely the one that you're going to want to take. Again, it's a combination of live and on demand. Every Wednesday, a lecture is released. And then on that following Monday, we meet for a live Q&A from 8 to 9 p.m. Eastern Standard Time. And then the 2-day course is typically 2 Fridays back to back. As far as dates go, our next run of Team Myo will be starting this coming Wednesday, February 1st. There are pre-learned modules. It used to be a little bit longer. We cut it back because there are pre-learned modules. So you'll have access to those. You can watch them at any point. Even if you want to sign up now, don't feel like you have to rush to watch those pre-learned modules. It is okay. So we start that February 1st. If you are an existing myofunctional therapist and you already have those basic foundations, but you're looking for a little bit more, you can join in on our 6-week private myofunctional therapy course, Team Myo course, which starts February 15th. So you will come in on week 2 of that 8-week course and you'll finish out with us. One of the great things about our Team Myo 8-week course is at the end, we do have a case study presentation where each participant will present their very own case study. So you're already going to leave the course having started working on your first patient. It's awesome. It's so much fun. Everybody gets to sit in on each other's presentations, and it's just, there's so much learning. It's really a great experience. Our next 2-day course, our dental practice integration for the registered dental hygienist, is April 14th and April 21st. And we are offering a flash sale currently of $200 off either of these courses. Do you have anything else to add, Karese, to the course? Talking about the course?
No, it's just a phenomenal course. You said so much.
Yeah, things maybe you want to know that we include. So we go over dental sleep concepts. We do go over foundations of myofunctional therapy, tethered oral tissues, the intake, the assessment, the evaluation, taking you through, Karese takes you through a full patient for treatment planning. We go over
troubleshooting.
Troubleshooting,
road
yep.
bumps you might hit, you get the road bumps, the oral habits, we do modalities, we do business and practice integrations. If you're trying to open up independently or you're trying to mix into the office, I mean, it's a little of absolutely everything.
What's really awesome is between Karese and myself, we both have done myofunctional therapy in like every which way that you can possibly do myofunctional therapy. So it's great through our experience. We're able to share that with you. You definitely learn from our mistakes. Don't make the same mistakes that we did. But it's really great. We have a lot of fun. Hopefully you guys had fun tonight with us. Just a little dose of what you can expect in our courses. And then, yay, Karese, you want to talk about our new course?
So we're really excited to announce that we're doing a 5-hour CE course about mini myo, how you can work with these different ages and stages. So we will talk about working with toddlers to a certain extent, preschoolers, and really understanding how you can create a solid foundation. Dr. Boyd teaches a phenomenal class for Airway Health Solutions about how you can really start to intervene. By the time they are at age 5 is what he says is geriatric for intervention. Is it age 5 or 6?
I want to say it might be 7.
Oh, okay. Well, we're getting older and older.
Yeah. It might be 5 or 6. Doesn't matter.
Yeah. I think it's 6 because he wants you to fix by 6. And
so yes, I love
this
that.
is going to be, this is going to be a wonderful adjunctive to that type of interest. So if you're interested in really getting into early intervention, if you're working with a pediatric doctor and you want to know how you can really help them by creating a solid foundation and work with these younger ages to help fix by 6, this wonderful mini myo course is going to be exceptional for you. And so you can get in on that.
Excited about it.
March 24th, 2023.
All right. And then we have our mini residencies with Dr. Moralia, the pediatric or the adult. You can take one or the other or both. The next pediatric mini residency is February 3rd, followed by the adult mini residency February 10th, and then it'll be offered a few more times throughout the first half of the year, April 14th, 21st, June 2nd, and June 9th. Feel free to visit the website to learn more information. Dr. Moralia's advanced mini residency, learn fixed expansion in teens and bracket and wire techniques, very exciting. March 3rd and 4th, it is 100% virtual. Treating the TMD patient. This course is offered by Dr. Michael Gelb. Oh, I couldn't see the date. It's literally right there. March 31st, guys. Sorry, I was panicking. I couldn't see it. So March 31st is our next course with Dr. Gelb. If any of you aren't familiar with Dr. Gelb, he's a renowned TMD specialist. Great guy. He talks a lot about really that collaboration between him and that ortho provider or that expansion provider. Him and Dr. Moralia, again, being in close quarters in the New York area, have definitely collaborated on a lot of cases. And it's really important, again, to have that collaboration. Dr. Brett Christensen, Airway Orthodontics. I love Dr. Brett Christensen. I think he is just so smart. Definitely a course you don't want to miss. I love it because he's an orthodontist, right? So sometimes people can't get off their high horses and they're like, general dentist shouldn't be doing orthodontist, blah, 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 blah. but Dr. Christensen would tell you that they're the first ones that should, if they're actually going to do it right and treat these patients. But
Yeah.
Dr. Brett Christensen is an orthodontist. So to be able to hear it from him, I love it. For any of you hygienists that are looking to network with other orthodontists, Dr. Christensen has been on, the town hall, the conversation series with Lauren. So you can go onto the Airway Health Solutions website in the podcast area. They're all archived in there, but it's a great source to be able to give to your fellow orthodontists, because again, this is who that they're going to want to hear it from. So his course is May 5th, and again, completely virtual.
Cinco de Mayo.
Oh, fun. And I think that is it. Let me stop sharing my screen.
Awesome. Thank you all guys for joining us all tonight. We are super excited to have been able to answer those questions for you. I know some of you may have more questions. You can find Brittny and I on Facebook in the Out of the Op and Into Airway Facebook group, or you can join the what's the Airway Health Solutions group? It's DDS OMT meetup group or something like that. I just butchered it. Sorry, Lauren.
Gerald, if you're there and want to type it into the chat box, that would be awesome. But yes, find us. We'll give it to you. Contact us on social media. Join our Facebook groups. We do offer, Q&As throughout the year. Answer any questions that you have. So again, we look forward to. Here we go. Gerald always coming in clutch. Airway Health Meetup. Yes.
We're in
all right,
all
guys.
these groups.
Well, we hope to see you all again soon. Hopefully some of you will see in our Team Mile courses. So nice spending the night with you all. We wish you a great rest of your night, and we'll see you next time.
Bye.
Bye.